sometimes you just have to like practice based on a hunch. And, of course, you're trying not to harm the patient and you're letting them know, here's in theory why this may or may not work. Here's what we know. Here's what we don't know, the risks, the benefits. But that's kind of how you have to practice.
Welcome back, every Bendy Body, to the Bendy Bodies with the Hypermobility MD podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. Today, I am so excited to speak with Dr. Matthew Watto. Dr. Watto is an internist, and he is a co-host of the podcast, The Curbsiders. It is important to have empathy, compassion, and understanding for your internist so that you can learn how to work with your doctor and get better care. Dr. Matthew Watto is an internal medicine nerd, clinician educator, and podcaster. He is a clinical associate professor of medicine at Sidney Kimmel Medical College, an adjunct associate professor at Uniformed Services University, and has received numerous teaching awards. In 2015, he co-founded The Curbsiders, a weekly internal medicine podcast that uses expert interviews to bring listeners clinical pearls, practice-changing knowledge, and lots of bad puns. The Curbsiders team uses its platform with over 100,000 active monthly listeners to bolster frontline clinicians caring for millions of patients across the United States and internationally. This is such an important conversation because for so many people, their internist is going to be their primary care doctor. And so it's essential to work with your primary care doctor in a way that can get you the care that you need. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. Okay, well, I'm so excited to be here with Dr. Watto today. How's your day going?
My day is going well. And I don't know if you weren't prepared for this. I didn't talk to you about this ahead of time, but on our show, the Curbsiders, we always do like a pun to start it off. I just feel like it starts things off with a good energy. So I typed into ChatGPT, can you give me some puns based on, flexibility, hypermobility? And I promise they're not, I think they're not great, but we'll try them out, okay? And if
Okay.
you hate, I think it'll be good. If you like puns, it'll be good. If you hate puns, it'll be good because
Okay.
it's, all right. So first one is people say I'm too flexible, but it's not my fault that I like to bend the truth. All right, so that's not great. And then the other one is I told my wife I was too flexible, and she said, "That's a stretch." Yeah, so Chat GPT is still working on it, but
Uh,
usually we started off doing puns that were related to the topic at hand, and
mhm.
then after getting to hundreds of episodes in, I just try to find any pun that is, just any pun that makes me chuckle. But for today, I tried to keep them relevant to the topic.
I appreciate that. I have heard that on your show, and I think that's a cool way to start. I like it.
Yeah, I think you gotta come into it with a good energy, excited to record. So thank you so much
Yep.
for having me, and I'm excited to talk with you.
Yeah, I'm super excited to talk with you because I know so many people are so frustrated how to get better care, how to work with their internist in a way that, is really helpful for them. And I know that you talk about so many amazing topics on your podcast, Curbsiders. It's such a great show. I know I've learned
Thank
a
you.
lot from listening to it, and I hope people will go check that out. We'll be sure to link your show in the show notes so people can check out your podcast also, because it is really important and you cover so many great things.
Yeah, I appreciate you saying that. And I mean, I think much like your show, we try to make it practical. We try to make it pertinent to like our audience has these pain points, so to speak. They're seeing patients with certain complaints. They might not know how to handle it. So we try to get an expert in that can teach us how they would handle it. That way, in primary care, or we have hospital medicine shows too, we can sort of, help people help their patients more. So it's a really great format to do that, which is why I think podcasting works so well for medical professionals.
Yeah, podcasting is, I think, a great way to teach for sure. So, can we start out by talking about what an internist does and what role they might play in the person who has a connective tissue disorder like hypermobile Ehlers-Danlos or hypermobility spectrum disorder. And, oftentimes they're trying to assemble their team, if you will. And I think it would be important for people to understand right off the bat what that means and what kind of a role that person might play.
Yes, okay. It's a little hard sometimes to, like, explain an internist to, people. They're like, "What do you do?" And I usually either say just like, "I'm a primary care doctor," sometimes I work as a hospitalist, or I might say to them, "Well, if someone's admitted to the hospital, we take care of pretty much anyone who's not on a surgical service. So we can take care of just any host of things, high blood pressure, diabetes, cholesterol, infections, heart failure, kidney failure, just really a lot of, we're sort of like the undifferentiated physician. And then you can become a kidney doctor, you can become a heart doctor, you can become a lung doctor, all those things from starting as an internist. So it's really you're kind of a generalist, but you see adults, you don't see kids,
Mhm.
and you see pregnant women, but you're not taking care of pregnant women in the hospital the way a family medicine physician would be.
Right. So that's an important distinction between an internist and a family doctor, right? The family doctor will handle all ages, and whereas internists are going to be managing adults.
Yes.
Yeah.
And I
Okay.
should say to your audience, like, in this full disclosure, we have very poor training in hypermobility, Ehlers-Danlos. Like, we've heard of it. We know it's out there. I was talking to my partner on Curbsiders, who has, throughout his career, at some points, he's had actually just ended up with like a panel, a lot of patients with hypermobility and pain from that. So he's a little more familiar with it than I have been, but it's something that I think internists should know more about. Like,
Mhm.
there's definitely training gaps in, like, when I was going through training, there was no training in addiction medicine. That's actually becoming fixed very rapidly now. A lot of
Mhm.
internists are getting, just because there's so many patients that need our help, that we've just sort of by default become comfortable with addiction medicine. And I think, for hypermobility, that's maybe something that internists should become more, or they should become more familiar with that. But your training in med school, I can't remember a single lecture, and then going to national conferences for the past 8, 9 years. I don't remember. I know I haven't attended a lecture, and I
Mhm.
probably would have if I saw it, because it would be such a unique topic.
So I would love to connect with you offline about that because I would love to submit a lecture to do at one of those conferences because that's so important. Like up to 3% of the population may have hypermobile EDS or HSD. And so this is a huge percentage of people because I'm sure they're overrepresented actually in your clinics. It's not 3% of the visits. They're probably many, many more than that because they're having so many different symptoms and problems. So internists definitely need to be as familiar as possible. And what I say all the time is, these patients are coming to your clinic. You probably just don't realize it, and no one else has made that association either. I
Yep.
personally have hypermobile EDS, and I had been to, my physical medicine and rehabilitation doctor. I'd been to multiple orthopedic surgeons, and even if they did measure my joint range of motion, and they would say, "Oh, well, it's way higher than normal," they would never say what that could possibly mean, or think, "Okay, well, this person has complaints in other parts of their body. Maybe I should refer them to a rheumatologist or whatever." Which
Right.
ultimately, that's how I got diagnosed. But I do think it's such an important thing for people to recognize because unlike the myth that there's nothing you can do, there really is a lot that you can do. So the internist, which is why I'm excited to have you here, the internist can really play a very significant role in the care of these patients. And I try to explain to patients all the time, you can't expect the internist to be an expert in this because they have to be an expert in so many things. They have to know, like you said,
Right.
how to manage high blood pressure and diabetes and you know, acute things like acute infection or
Sure.
whatever. But having some awareness, I think, would be really important.
I think that's true. And, part of what has made me, like, do a podcast on internal medicine for the past 9 years is that I just learned that, okay, so many patients, they're waiting to see a specialist, or they just don't have the relationship with a specialist. And when we can really learn the majority of the workup, get them like 80% of the way there for a lot of topics, start the workup, we can interact better with the specialist if we have like just at least a core baseline knowledge of things. I think that is, you can definitely expect that from your internist, or we should aim to get there for this condition, where someone like myself, like, this has kind of spurred me to start doing more learning on this when you reached out to me because like I said, I admitted it's not something I knew much about. I've heard about it, but it is something that I think we could do a lot better than we are now because right now we're doing terribly. So, it's like we could definitely do better.
Yeah, yeah, I agree. I think there's so much room for improvement, and again, it just I tell people when they say, "Oh my gosh, my doctor didn't know how to pronounce it," or they were looking it up on Google, and I was like, "That's great that they were looking it up on Google." And if they didn't know how to pronounce it, like that's okay. That doesn't mean that they're not going to be able to help you.
Yeah, absolutely.
So when you are, I guess not just you, but in general, internists that are within the insurance accepting world, how long would you say the average appointment is for a returning patient and for a new patient?
Yeah, it's definitely variable. I can tell you in my experience for returning patients, it's usually 15 to 20 minutes. And then for new patients, you might have 30, 40, or if you're lucky, you might have an hour, but most places are like 30 to 40 minutes with a new patient. And the I think in some clinics, like some family medicine clinics, I've heard them say you have 5 or 10 minutes, and I've had some patients that are physicians even say that like they went to their their primary care, and the primary care said, "Okay, you're here for a physical. We can't talk about any acute
Right,
complaints,"
right.
and they sort of limit that visit. Because I've always worked in academic medical centers. You have a little bit less of that pressure to see high volume, so I've always had, like, the luxury of having a little bit more time with my patients. So, like, I think 20 to 40 minutes. In 20 minutes, I can usually do a follow-up if I've done a bunch of preparation ahead of time. And then, if you run a little over, it's okay. And 40 minutes, you can, if you've done your work ahead of time, like whatever you can learn about the patient before they get there, you can do a pretty good visit in 40 minutes and address like a couple acute concerns. And so I think anything once you start to get down into those, like, 20 minutes or less, if someone has a bunch of complaints or they have, like, a big emotional thing to talk about, it's just unrealistic, and the person's not gonna feel heard probably leaving that visit.
Yeah, and I've definitely been on the receiving end of that. Like you said, you're coming in for just a general checkup and you have a pressing concern and nope, can't talk about it right now. And that's always challenging. So you just brought up about academic medicine. So what are the different types of practices and why is that important for patients to understand?
So, in academic medicine, it probably means if you're seeing someone who's in academics, it probably means they're spending a lot of their time with trainees, whether they're medical
Mm,
students or medical residents. So they're not going to be in clinic 8 or 9 half days a week. They might only be there for 5 or 6 days, like half day sessions,
mhm,
and they're going to. So their time is going to be a little bit more fragmented, um, but they might have less of a time pressure. Depending on where they work, they might have less of a time pressure to see that high volume because they're not expected to be these sort of like workhorses. As sad as it is in medicine, it's like, this is my cynical view of how the system largely works is like, if you're primary care, they want you to see as high volume as possible, as many patients as possible, because that's they don't you don't get reimbursed a lot per patient, so they just
right.
want you to see a lot to make a lot of money. And then uh for surgeons, like you want to keep all your surgeries booked, max out as many surgeries as possible, as many procedures as possible.
Yep.
Keep if you own the CAT scan machines and MRI machines, keep them running like 24/7. Unfortunately, that's kind of how things are incentivized. And, some some practices, you can feel that when you're there, that they're just,
Mhm,
rushing through things as fast as they can. I like to think that some of the practices I've worked in, because of its academics, they're a little bit sleepier. You get a little bit more time with the patients. It might be frustrating that you can't see like if you call for a same day visit. I think that's always hard in any practice, but
mhm,
that might be hard. So we do more telemedicine for some of that stuff,
mm.
just to try to like at least have that contact with the patient and make them feel like even if you can't see them in person that day, you do a telemedicine. So did that answer your question? I mean, I could go on about this stuff forever.
Yeah, yeah, no, that's okay. So you're in academic medicine. So you're in an institution where medical students and residents, et cetera, are being trained. So that's
Yes.
different from a private practice where there could be different types of private practice,
Sure.
but like you said, that depending on who's overseeing the clinic, there could be that higher volume type
Yeah.
situation. So I guess I'm thinking for a patient who's trying to figure out who they should see, are there
Mhm.
certain questions that they should ask if they feel like, I'm kind of complicated and or I really want to have more time with my doctor? Are
Mhm.
there certain questions that you think they should be asking when they're investigating different doctors
Right.
that they might want to consider? Yeah.
I think they definitely should ask about the how long that you get for new patient visits and follow-up visits, because if they're 30 minutes for follow-up and 60 minutes for new patient visits, that's better. More time with your physician is better. I think you can ask things about, like, is this a training site? Because sometimes if doctors have trainees following them, they might kind of have a slower schedule and more time to spend with the patient to allow for having that trainee there.
Mhm.
And then there's concierge practices. Sometimes they call it direct primary care. Usually that's where you have some sort of a fee that you pay, almost like you can think of it like a retainer, might be $2,500 a year. And that doesn't that means, so if an internist has a panel of 1,000 patients and each one of them is paying them $2,500 as a retainer, that allows them to only see 10 or 11 people a day. They can spend an hour per patient. They usually guarantee seeing you within 24 hours. Obviously, you have to be privileged enough to be able to afford the retainer, but those practices, like if you're someone who's complicated and you have the means, those are often good to look into because you have a lot more access, and your internist might even follow you. Like if you get hospitalized, they might come visit you in the hospital, which is not a common practice anymore.
Right, right. Medicine has changed so much since I graduated from medical school and you went through residency and everything. Yeah, it used to be that your primary care doctor did follow you into the hospital, right? And then
Mhm.
now we have hospitalists who stay in the hospital. Well, they don't. I almost made it sound like they live in the hospital.
Yeah.
They don't. They don't live. Well, they might feel like they live in the hospital, but I remember when I was interviewing, I think my husband interviewed there, I didn't, but I don't know if you've heard this because you're probably a lot younger than I am, but at Baylor, apparently they had a line and you weren't allowed to cross that line if you were like a surgical resident. Supposedly, you weren't allowed to cross that line except for like once every 6 weeks. I don't know. That's what I heard.
Wow.
Yeah, yeah, crazy. Things have changed a lot, that's for sure. So, the hospitalists now, right? They work at the hospital. They don't have their own patients, if you will. They don't have their own practice, but right. So that's a huge advantage if you are complicated and if you can afford it. If you do get hospitalized, that again, you can ask those questions that that person might
Yeah.
actually come and see you in the hospital and help guide your care.
And there's a couple rare groups now that will still follow their own patients in the hospital. So you could ask about that, like if I
Hmm.
get hospitalized, will this group follow me in the hospital?
Hmm.
There that is still around a little bit, but it's really not common. And the hospitalists they basically they admissions come through the ER. If they're not going to surgery, they go to a medical service, and then the hospitalists just kind of get randomly assigned patients. And if you're unfortunate enough to be in the hospital all the time, you might start to get to know some of the hospitalists, but there's really not the continuity there.
Right.
And in general, I would say the communication to primary care physicians is not great. Like
Hmm.
sometimes they'll call you as a primary care physician, but I work as a primary care physician, and it's super rare for me to get a call from a hospitalist. I may reach out to them because it's often my patients are being admitted to the same hospital my clinic is attached to. But I think communication in general in healthcare could be a lot better, and
Hmm.
if people were incentivized to talk to each other more, but
Yeah.
it can be hard to get a hold of somebody else. And so, but I'm pretty liberal with giving just calling somebody or texting somebody and saying, "Here's my cell phone. Please call me back. I want to talk to you about this patient." And I
Hmm.
think we need more of that.
Yeah, definitely. And it's also interesting because my husband, who's a urologist, when he retired, his practice actually started doing Euro list. So, like a hospitalist, but for urology.
Oh,
So,
wow.
yeah, yeah. So things have evolved even within some of the specialties where they have somebody who rather than going back and forth, because that would happen to him all the time. If he was on call, he'd be in the clinic and then he'd have to run over and then run back. And it was just incredibly disruptive. So then, his whole clinic would be delayed for the rest of the day. So maybe he would have a longer time blocked out for people, but now all of a sudden, staff is going to leave at 5 o'clock. So now you have to get all of these people in before before the end of the day, which is tough.
Yeah.
So
I mean, I will say to the patients that are listening, I think everybody that goes into medicine, I mean, there's better ways to make money in the world. Like
right,
everyone that goes into medicine goes in like wanting to take care of people.
right.
And then the system just sort of warps things and changes things and you're just part of a system it should be patient centered. It should be all like geared towards patient outcomes and maybe health systems will like tell you that's their motto and everything, but unfortunately, at the end of the day, like a lot of things are just incentivized against the patient,
Mhm.
and so it is tough. It's a challenge for us, even trying to like you come in with this like you want to do right by patients, but it's just hard in the system. You only have so much time in a day, and you're feeling rushed. This pressure to get people out of the hospital, see as many patients a day as you can, and it definitely erodes the quality of care. So that's how it is. Hopefully it will change, but
Yeah, no, I totally agree. And I think the other thing that's really challenging is, at least for me, when I was working as an anesthesiologist fairly early on in my career, I was raising children also. So
mhm,
with the spare time that I had, I was with my family and I was working full time. So I wasn't able to do as much reading. And of course I did all the mandatory, CME hours and I'd go to conferences and
mhm,
things like that. But it's not like now where I don't have children at home anymore. So I can spend a lot more time reading and I can do a lot more of the things that I feel like do enhance my ability to take good care of my patients. But
yeah,
when doctors are young and they're fresh out of training and they probably have a massive amount of debt, so they often end up taking jobs that, will help them pay off that debt. And I think a lot of patients, they especially the complex chronically ill patients really get caught in the middle of that and they really suffer the most because it's just so challenging. Those doctors, like you said, they're seeing a high volume of patients. They're not able to kind of take care of themselves because they're raising children or
such a good
whatever.
point.
Yeah, yeah. So I think it's important for people to understand that because I agree. Every medical student that I've ever worked with, and I've taught in a medical school not too long ago, um, they, like you said, they want to take care of people. Their heart is absolutely in the right place, but the training and the systems that we work in just are really damaging for that.
Yeah,
Yeah. Well, let's talk about what often are called like practice extenders. So, physician's assistants or nurse practitioners. So, I feel like this has also evolved over time where, well, they didn't used to really be around at all, as far as I know. But now, there's a lot of physician's assistants and nurse practitioners. And there's different types of practice models that I feel like people will have. Sometimes they might see that person first and then they see the physician. And other times that's all that they see. And I believe there's probably differing state regulations
yeah.
depending on how much independence they can have. Do you think that there's a way to help patients know when it's a good idea to see a nurse practitioner or PA and have that person kind of guiding your care versus when, no, you really need to have a physician involved?
Sure. And I should say that we have in our audience at Curbsiders a ton of physician assistants and nurse
Hmm.
practitioners, pharmacists, um, people that are just like super curious the same way we
Hmm.
are, trying to learn how to better take care of their patients. And um, I think what part of what I've learned is there's a huge spectrum, just as there is with amongst doctors. There's a huge spectrum of like what was their prior experience, what was
Hmm.
their training like, because if you're in a residency program, which I've worked in for the past 13 years, um, a residency program, they have a group of people. It's like a committee of people that follows all the residents in the program, make sure they're meeting milestones. You get all these evaluations, you sort of evaluate their clinical performance, and you're making sure they're meeting milestones to go forth. And in some of the nurse practitioner physician assistant programs, they don't have it's a little bit less decentralized.
Hmm.
So they might not get the same quality of feedback and they're not spending as much time in that like training environment. So a lot of them, I think a lot of the reason they love our show so much is because they come out and they're like, oh my gosh, like I learned a lot, but I feel like I have so much more that I want to learn and I want to take the best
Mhm.
care of my patients. So they're consuming like all these podcasts to try to learn about all these conditions and they're reaching out to us with questions and everything. So I think, like, it just depends, I don't think there's any difference in intelligence, there's a difference in how long someone's been in training, and in general, the way a lot of practices work is, like, let's say a cardiology practice, they have nurse practitioners, physician assistants who will see a lot of their follow-ups, they'll manage heart failure, they'll manage certain things like atrial fibrillation, and, they will see a lot of the follow-up patients. A lot of the times, if it's a new patient with a lot of undifferentiated symptoms, that person's going to see the cardiologist first and then they'll see the nurse practitioner.
Mhm.
Um, in some of the internal medicine practices I've worked, the nurse practitioner, it's you don't really have that much different between the patients that they might get and the patients that the physician would get.
Mhm.
And hopefully the practices are collaborative. So if someone feels they're over their head, they can sort of hand it off to another person. But I don't think you can really say, like, just going in the door that I need an NP or I need
Mhm.
a MD, DO, PA. I think you just have to meet the person because you might like the NPPA might do a much better job than the
Right.
MDDO. It just depends on what's going on and what you need. So I think you kind of have to shop around. Like, I don't know that you can tell until you've met the person.
Right. Well, the one thing that I often ask, when I'm needing to go into a new practice, I often will ask, well, how long has that person been doing this particular thing? Because, of
Yeah.
course, if I suddenly wanted to practice orthopedics, I can't do that. I can't just
Right.
suddenly switch from being an anesthesiologist doing pain medicine to doing orthopedics. I'd have to go back and do another training program.
Yeah.
Whereas, since, like you said, the training is a little bit different in that regard. So I've worked with PAs in orthopedics who are phenomenal. In fact, I've worked with somewhere, like, basically they were doing the surgery, and the orthopedic surgeon is kind of, but part of it is because they were in that specific specialty for that many years, so they got incredibly good at
Yeah.
it. So I think that's an important thing to ask, because sometimes, if they did podiatry first and then maybe they did, cardiology, and then maybe they've done a few different types of
Hmm.
specializations, or maybe they did internal medicine and then they did a specialization. And if they're relatively young, then I think maybe that's an important question to ask and can be helpful sometimes. But you're right. If they have, which is very common, right? They'll have often more time to spend with you. A lot of the practices are set up that way. And so that can be really, really beneficial, because then you can actually get more of a deep dive into the things that are really problematic for you.
Yeah. Yeah. I mean, I think in just any medical practice, hopefully when you're working with somebody, um, they're listening to you. They have the humility to recognize when they're in over their head and they need to call for help or get a consultation to help you out. And I think that that goes for whether it's a physician or an advanced practitioner. And um, yeah, we're always like, I'm always like a little anxious talking about this topic because I just want to make it very clear that I think like there's no, I'm just like very supportive, everybody practicing to the top of their capability and their, where they can safely practice. And and over time that will go up. Like, people can gain more independence, can gain more skills. That's true for anybody in any job.
Right, right. Absolutely. And like you said, that's something that you don't necessarily know right away, but once you meet the person and you get to know them a little bit, that's very, very helpful.
Yeah.
So, yeah,
Yeah.
totally agree. We are going to take a quick break. And when we come back, we are going to talk about chronic pain, or I like to call it persistent pain, so it doesn't sound quite so uh, dreary. But we're going to talk about persistent pain and the role that the internist can play in the patient's care. So we'll be right back. This episode of the Bendy Bodies podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos syndromes community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we're back with Dr. Watto, and I'm so interested to hear what you think about the role the internist can play in people with persistent pain. Oftentimes they don't know that joint hypermobility may or may not be a factor. Like I didn't know for decades that this was something that was playing a role for me. I did ballet growing up, and it was very helpful to be super bendy, but as I got older, of course, I started running into more problems. A lot of people will initially see their internist when they are having pain. Of course, it could be acute or it could be chronic. But what do you think is the most helpful way that the patient and the internist can work together?
All right. I've been thinking about this topic a lot lately because this is something that I lecture on in my day job, and something that when I first entered practice out of residency, I was very uncomfortable managing chronic pain. And so I really wanted to learn as much as I could about it. And one of the first episodes we did on the podcast was fibromyalgia with a
Mm.
fantastic Dr. Claw from University of
I know him
Michigan.
well. Yes.
So he's
Yeah.
he's a great guy, and taught me
Yeah.
a lot about this chronic pain. And from there, I've just sort of tried to keep up with things. But I will say that hypermobility is something that I'm gonna have to add that to my like sort of history when I'm taking a history for pain. But I do think that it's really important for anyone with chronic pain. I always tell them, listen, like you've had this pain for a long time. It's gonna be hard. It might take us a little while to figure out, like, what's gonna make you feel better. Is there an underlying cause that we can identify or not? And, but I'm gonna work with you. I think you just have to give the patient that, like, "Okay, this person's gonna partner with me. They're with me for the long haul. We're gonna figure this out," and I will see them frequently. Maybe it's once a month, maybe it's every 3 months, but it's not someone that I'll see, like, once a year and just throw some meds at them and tell them they're gone. And I am usually talking about, I'm taking like a full history, and this biopsychosocial model, I think is I don't think it's outdated. I think it's you can't just, I think what most physicians are trying to do is just address the biological piece of it. They're not asking anything about the patient's social history. They're not, assessing their mood and their sleep and all these other things that factor into pain. So I always try to like really go in depth, like, who is this person? What's gone on with them medically? What's going on with them emotionally? What's their home environment, their work environment like? And that is you may have some clues there that help you out.
Yeah, no, I totally agree. I feel like with the biopsychosocial model, that there are people who are very much practicing the biologic side, and there's people who are practicing the psychosocial side, but blending those together is what's really important. And the approach that I take, I have an acronym for it. It's MENS PMMS, and those letters stand for movement, education, nutrition, sleep, psychosocial, modalities, medication, supplements. So those are the 8 parts that I try to incorporate into every comprehensive treatment plan because, like you said, it's not just here, I'm going to write you a prescription and your pain is all going to be gone. That's not how that works,
Yeah.
unfortunately. So, do you see patients with chronic pain very often?
All the time. Yeah. I mean, it's fortunately, it's not every single person I see, because I think it is, I'll be honest, it's emotionally draining for us too to see patients with chronic pain, because the patients have that feeling of helpless, and often there's like this transference of like, you're like, oh my gosh, like I'm trying my best, I can't even, in some cases you can't think of things, or you're suggesting things but they're not working. So it's hard on all parties involved. um but yes, I think any physician that's practicing primary care, you're going to have patients with chronic pain in your practice. And whether it's like migraine headaches or fibromyalgia, or just chronic joint pains. Some people have chronic back pain. Those are some of the really common ones. Like I said, I'm probably gonna. I think everybody, all my internist friends, have to re-examine their panels for like who might have hypermobility that we're missing in the panel. But yes, we definitely are. It's something we see and we think about.
Yeah, and the symptoms that can come along with the connective tissue disorders are so widespread. So people will come in and they'll be complaining of, fatigue or, dysautonomia type symptoms. They may or may not meet the criteria for POTS, postural orthostatic
Mhm,
tachycardia syndrome, but they have orthostatic intolerance. So, they get dizzy when they stand up. They've got the black shades, coming in. They're pre-syncopal, or perhaps they actually even have syncope.
mhm.
And GI problems. So you see a lot of, GERD, small intestinal bacterial overgrowth. You see diarrhea, constipation, food intolerances, allergic type phenomena. So if a person comes in with these complaints, oh, I feel fatigued. I'm so tired. I have all this pain and I have these problems with my stomach. And, so oftentimes I feel like the internist, especially if they have a shorter amount of time, they're going to be pretty overwhelmed with all of that. So I love that you're already thinking about ways to screen for this population because you're right. It can be really exhausting, but at the same time, when you can work with that person and actually help them feel better and help some of these really complex cases, it's so rewarding for you and for them, because they've been sick for such a long time. So they're so happy if they can finally start to feel better. As I'm describing that type of patient that I see every day that I'm seeing patients, which I have a very small part-time, medical practice. So, does that sound familiar? Are you seeing people that kind of fit that description, do you think?
Yeah, and definitely, you get a lot of patients, like irritable bowel syndrome.
Mhm.
Of course, GERD is super common. Small intestinal bacterial overgrowth. That's actually something we're working on an episode now, like where it's a
Mm.
topic I feel I need to do more learning on.
Mhm.
But yeah, I had never really before like listening to some of your shows to kind of learn about this. I had not really made that connection with hypermobility at all. And like I told you, I was not really thinking about hypermobility for most of my patients. And it's not for whatever reason, I don't know how many patients make the connection either. It's not like people are coming in like, "Hey, I'm double jointed and I have chronic
Right.
pain. Do you think there's a relation to it?"
Right.
Like I
Right.
think
No, they're not.
it's just not in the public awareness enough for people to be, like, coming in with those kinda complaints, which, I guess, like, the work you're doing is helpful because now I think, you're spreading awareness of it, and, it'll eventually, like, more people are gonna learn about this, and hopefully you'll make more diagnoses and be able to help more people. But, yeah, absolutely. I mean, there's um, so many times you get this constellation of symptoms and you're trying to figure out like what could this be. You do lab testing, and I think what probably your audience knows is that if you order conventional labs thinking of only conventional diagnoses, a lot of times they're going to just come back normal, and then you're going to say, oh well, like the workup we've done is normal, so I don't know what to tell you, you
Mhm.
know. And I think a lot of people have probably run into that.
Yeah, they definitely have run into that. And it's true for labs and it's also true for imaging, right? So because
Hmm.
imaging is most of it done statically and
Yeah.
often it's done in a position that is not the position that exacerbates the person's problem. So they could
Hmm.
be getting a supine MRI, for example, or some other study, and really what they need is something that shows the motion and yeah, it's really fascinating because I feel like if we just changed the way that we described things rather than saying, basically or implying, "Oh, your labs are normal, your imaging is normal, it must be in your head. I don't
Hmm.
believe you, it must be in your head." But instead, if we were to say, like what you just said, for the things that we were screening for with the labs and the imaging, we didn't find anything, worrisome there. But I believe you, and I'm going to help you with your symptoms that you're struggling with, and we can always dig deeper if we need to later. But let's start working on some things that we can try or whatever. So they feel like they're being supported and not, X-rays were normal, therefore you're fine. And it's like every test has limitations. We don't
Yes.
tell people that.
My friend, Dr. Iris Wang is a GI doctor, and she actually does like hypnotherapy for irritable bowel syndrome, and dyspepsia, and a bunch of like sort of disorders of the gut brain interaction. And she tells her patients, she says, "Listen, I'm going to do some testing. I think what you have is irritable bowel syndrome. I expect this testing is going to be normal, but that doesn't mean there's nothing wrong. Like I think so she kinda says, like, the testing being normal tells me that I think I know what's going on with you and I know how to treat it. So, I think that is a like you're saying, we need to reframe things, and, that's I think what's really frustrating for a lot of patients is because there's and I think we've learned about this in the past 5 years, at least I have, where a lot of people are trained in medical school. You're basically told, like, follow the party line, what these big organizations, if it's in an expert guideline, then that's you gotta follow that. Don't think for yourself, and I think people are starting to more think for themselves and just say, "Well, wait a minute, these big organizations, they get things wrong sometimes, and the scientific method is such that, like, you need to constantly say, like, "Oh, there's new information. I can change my thinking based on this new information that I've learned." And I think medicine in general needs to get a lot more humility and start to, like, accept that, and not that shouldn't be controversial to say that, but I feel like, um, you know, I don't wanna get into talking any politics about anything, but I just think that, if you ask me, like, what has changed most about how I think about the world and my profession in the past, like, 5 years, it would be just sort of, like, investigating things for myself. We do a journal club on Curbsiders where, like, just because that new drug got approved and they had positive results, I'm very skeptical, like, whether or not I'm actually gonna prescribe it for my patient because I know it is very easy to make a trial a positive trial, and do we care about the endpoints that they pointed to? And so, that's where I'm at, and that's why, I like as a person and as a physician, I like to constantly learn more, constantly evolve, and don't don't hold on too dearly to any of my current beliefs because they might change.
Yeah, I think that's such a great attitude to have. And, there's no FDA approved treatments for hypermobile EDS. So if we were to just go strictly off of that, we would not prescribe anything.
Right.
And
Which would
that's
be an insane way to go.
correct. It would be ridiculous because in the meantime, people are suffering and there are things that we can use that we can extrapolate from other conditions. And I just think, yes, it's important to read the double-blind randomized controlled trials and be looking at the evidence, but it doesn't all have to come in that form of a big study. And like you said too, things can get approved that are not necessarily the best idea.
Mhm.
And sometimes I say, you know what, let's wait a little while and see if things as they're prescribed to more people, there's much larger numbers, even though,
Right.
obviously they went through phase one, phase two, phase three. But now let's see as it gets applied to more people, are there other things that are going to come up that maybe are side effects that we would really, really want to avoid? So, yeah, I think those are really good points.
And part of the thing that we need to realize too is like, there's just certain if it doesn't make sense for a trial to be done financially, if there's not like then some a lot of the times the trial's not gonna be done, or it's too expensive, and
Hmm.
it's not gonna pay dividends down the line, so they won't do it even if it would ultimately give us good information and help benefit patients. So sometimes you just have to, like, practice based on a hunch, and of course you're trying not to harm the patient, and you're letting them know, here's in theory why this may or may not work. Here's what we know, here's what we don't know, the risks, the benefits. But that's kind of how you have to practice. And if there's no real strong trial to guide like what you're doing, you just have to that's the best that you can do. And you're essentially running an experiment on the patient with their consent and trying something, um and then you're reassessing. And I think that's the way to go.
Yeah, and I don't remember what the percentage is in terms of how much we're using things off label, but it's very, very high, right? So the drug gets
Yeah.
approved for some other condition, but like you said, the drug company doesn't pay tons and tons of money to go back and get it approved for another indication because that's really, really expensive and oftentimes not necessary. So we can prescribe things for a different condition, like you said, with the patient's consent and all of that. So it doesn't mean that the drug isn't safe. It just means that maybe it's not, it didn't go through those steps for that
Right.
particular condition. So that's an important distinction. And I also want to come back to something that you said earlier about the testing and things like that. So one thing that I feel like gets misunderstood a lot is functional GI problems, or I was diagnosed once with like a functional knee problem.
Mhm.
I've been diagnosed with hyperalgesia of my gastrointestinal tract and functional GI problems. I feel like people automatically in their heads go to, oh, it must be in my head. Now, of course, at the end of the day, that's where we sense everything, right? But in my head or in my brain or in my head versus like I made it up are two different things. So when it comes to functional gut problems, for example, or other functional disorders, would you agree that that's related to the function, not the structure? And so we should not be assuming that, oh, this doctor's saying it's in my head.
Oh, yeah, and I think, like, take it for what you will, but you should reach out to Dr. Iris Wang. She's, like, fantastic. She wrote a children's book called Boo Can't Poo. It's like a kid's book to help, kids with bowel movements, but, she's hilarious, and she's, like, the expert on this, but, yeah, like I was saying, the testing, they do an endoscopy, they're looking for structural problems, they can do
Hmm.
biopsies, but it's not they're not necessarily watching how your stomach moves and how it distends when you eat something. So, it's hard, and, she would be the one to be able to tell you because she alluded to me last time I spoke with her about this topic that maybe there are some things in research where they're trying to, like, be able to better make, like, diagnosis of functional dyspepsia, but
Hmm.
where people feel like they feel full too early or they feel uncomfortable when they're eating, and it's the way that the function of the stomach is just not functioning the same way, and they might be hypersensitive to stimuli that really don't bother other people, and that is a physical thing. It's just we just don't have tests to measure it. So, that that's kind of her world. But yeah, absolutely. I mean, it's dynamic studies are a lot harder to do, you know? I
Hmm.
I think that's it. Like, we have a barium swallow, which is where you're in an X-ray machine and you swallow some radio opaque liquid, and then they can watch it travel down, and that's one of the few functional GI tests that I can think of. I know they have another one where they put, like, a balloon with saline into the rectum, and then they have the person try to pass it, and I think you're sitting on, like, a glass toilet or a see-through toilet, and I hope I never need that study,
Yeah, me
but
neither.
it is like, they have some functional tests, but you can
Right,
imagine, like, a lot of people aren't signing up for that one.
right, right.
So it is hard, but these are very common. They can be treated, and, but it's just like the conventional test, you're not gonna see that, but it's very well documented that this is they call it disorders of gut-brain interaction, and it's
Hmm.
like, we talked about the biopsychosocial model. For this, it's like there's just the signaling between the brain and the gut is just kind of for whatever reason, it's not working the way it should. It's become sort of, maladapted, and so
Hmm.
normal stimuli that wouldn't bother some people are causing you great pain, and that's the way it is.
And I hadn't thought about this before, but a lot of my patients have had gastric emptying studies. So, you eat radioactive oatmeal or eggs or whatever, and then they're
Yes.
watching that pass through the GI tract. So that's another functional type
Yeah.
study. But of course, we know that the sympathetic nervous system, which is the fight, flight, or freeze, and the parasympathetic nervous system, which is the rest, digest, restore, are going to affect the function of your gut. So if you're particularly anxious when you go in to have that test, is that going to alter your results?
Yeah, good point. Good point. That test, I have ordered it for patients, and sometimes it's like pretty much a slam dunk, like it shows gastroparesis,
Mm.
but, it's other times you can almost just from the clinical history, you get a pretty good sense if someone has gastroparesis or not.
Mhm.
But that is it, and that condition can really be terrible for people.
Mhm.
It's some of the most uncomfortable patients I've seen have had that condition.
Yeah, interesting. And what about long COVID? Do you see a lot of long COVID? Have you found any, not to completely pivot, but,
Mhm.
a lot of people with hypermobile EDS or HSD or dysautonomia or mast cell activation syndrome, a lot of them either have had, persistent symptoms related to COVID, or they had a COVID infection, and that really just, led to a spiral of their other symptoms. So is that something that you've seen very much of in your patients? And have you been able to successfully treat that at all?
So I'll be honest, I haven't seen as much for as much as I've read about it. We've done Curbsiders episodes on it back back at it's been a couple years at this point. I haven't seen a ton in my practice. I definitely have had patients that had weeks to months of protracted brain fog and just, respiratory cardiopulmonary symptoms after a case like dizziness and things like that after a case of COVID. But it's been less and less, I guess, as we get further out from like OG, what I call OG COVID, like the
Uh-huh.
original, like big bad version.
Mhm.
Cause back then I was seeing a lot more of it. Um, and I think it's probably, I'm sure for your practice, like you're probably almost like a specialist, like you're gonna see more like a cardiologist is gonna see more heart failure and AFib than I am because people are like kind of know to go to them for that. So I don't see as much right now, but I guess that's both fortunate and unfortunate. But how about you in your practice? Is it still a pretty common diagnosis?
Yeah, yeah, it's I see it quite commonly, less so, less I would agree that less so in the last, couple of years, but definitely people are reporting that, I was doing quite well until something specific. So it could be a concussion or a car accident or,
Mm,
something like that, or it could be that they got COVID. So yeah, it varies with the person, but yeah, I'm still seeing a fair bit
mhm.
of that.
Yeah, and that I mean, that's another one of those ones where one of my big takeaways from our discussion with the expert on that was that like you sort of prepare the person ahead of time like we're going to do testing. It very well likely will be that the testing doesn't find a specific thing, but that doesn't mean what you're experiencing is not real. It just
Mhm.
means that, we don't have the right test to diagnose it, and we're still gonna work to treat your symptoms and get you feeling as good as we can, and, there were most of the big I'm in the Philadelphia area, so the big hospitals there each had like their own long COVID clinic, which was usually multidisciplinary between like cardiology, pulmonary, physiatry, those kind of things.
We kind of started out this way, but I want to circle back to the healthcare system and how patients can work as well as possible with their internist and with their whole team. So, what problems do you see arise when people are seeing doctors from, multiple different healthcare systems, and what can be done to try to mitigate that?
Well, I would ask your physician to have a conversation with your other physician or, nurse practitioner, PA, whoever it is, because I do think that uh, making people talk to each other can definitely help the situation. So if I'm seeing somebody and they're maybe they're upset or they're telling me they don't understand what's going on or I don't understand what's going on with the specialist they're seeing, I will call that office, leave my cell phone number and say, "Please call me. I would just like to talk it through, see so that I can better work with you and better counsel the patient." Because I think sometimes people they use a whole bunch of medical jargon when they're talking to people or they don't take the time to explain it, and so I usually will try to do that. So I think asking your physicians to talk to each other would be important. There are there and then if you know that there's no electronic records connection, the Philadelphia area has a record sharing, between most of the major health systems, which is helpful. But if you know that you're outside of that system, making sure you get the copies of the images and the office notes, and so that you can bring them to your physician, that's really helpful for us so that we can, have as much information as possible when we're trying to tell you what to do.
Yeah, I suggest that people have several different documents. So, like a medical binder that has every significant, doctor's note, right? The full encounter note, just not just the summary, but the full
Yeah.
encounter note. all the imaging studies, especially if they were positive, but any imaging studies, like and have a tab, like a tab for imaging, and then have know if it's in reverse order or oldest to newest or whichever order you're going to do it
Mhm.
in, and like lab results and things like that. But then also have like a one sheet summary that has your medications, your allergies, your most significant diagnoses with an ICD-10 code if possible. But it's hard. We put a lot on the patients, especially like I mentioned, I have a very small practice, so I'm not on Epic. I can't afford Epic. It's way too
Yeah.
expensive. I have an EMR, but it's called Serbo, but it doesn't integrate with anything else. So the patient really is that continuity, that thread. So if they can be the one to have their history and all of their documents as organized as possible, then we're not having to, you know, wait till we, might consider getting another, MRI of the brain or
Yeah.
something when actually they had that done not that long ago. So I think that's very important. And then sometimes people get conflicting recommendations. So besides talking to each other, which of course, and that's absolutely ideal. But do you have any other suggestions for patients if they've seen multiple different people and they're not on the same system and they say, "No, I don't have time. I can't talk to your other 5 doctors." But they've gotten some different recommendations. Any thoughts?
Yeah. That's challenging because, I mean, you can see like, you can just see in general in life right now what's going on, like, in our country that, like, with the same set of facts, you can get very different opinions.
Right.
And
Right.
there's no magic about medicine that like, the medicine will have the same kind of thing. Like, you can give the same set of facts to multiple different people, and they will come to different conclusions and make different recommendations. So you have to understand that. And it's good to get a second and third opinion, but you just have to understand they might not all be the same. And yeah, at some point, you're going to need to make a choice. Who's giving you the better vibe? Like who makes the better case for why we should do one thing or another? So that's I would just say that to patients. I think if you have like a good internist or just like kind of like a quarterback doctor that
Mhm.
or advanced practitioner that you trust, I think like sort of let's say you need an ankle surgery or something and you're getting two different opinions. Well, maybe you talk with your internist about it and maybe your internist can help you and maybe they need to make a call and talk to one of those people. I think that's the way to go. I think it's if you have nobody that you trust that you have a long-term relationship with in medicine that can advise you, it's hard to know what to do.
And patients often want to know when they should switch doctors. And, I often say, well, if you're feeling like he's just not that into you, that's, just like the movie and the book, that's a sign. But do you have any tips for when people might know this isn't a good fit, might be time to look for somebody else?
Well, yeah, I would say the he's just not that I mean, you really boiled it down there. There's not a whole lot to say beyond that. But I think if you feel like they're not listening to you, if they feel maybe some people want a physician that's more directive and is just telling you what they think you should do.
Hmm.
We talk a lot about in medicine now shared decision making where
Hmm.
you're sort of admitting to the patient, look, like here's the facts. You could do this, you could do that. Maybe you say, I think this would be best to do for these reasons. I don't have a problem giving the patient like if you were my family member or if I was in
Hmm.
your shoes, here's what I would do. And but I think if they're constantly pushing you to do things you don't want to do or they're not listening to you, then I think then it's probably time to move on
Hmm.
because it's like the paternalistic medicine days, I think, are largely gone in this country. I know, um, I've worked with a lot of international trainees, and in
Hmm.
some other countries, it's still very paternalistic, and I think that's a function of that the public is just not their health literacy is way low. Like, so it's like only the people in medicine know anything about health in certain places. In the
Hmm.
US, people have such access to information that
Hmm.
your average healthcare consumer is savvier, and that's why shared decision making here makes more sense.
I'm so glad you pointed out about working with international trainees. So we did a survey recently for the podcast listenership, and surprisingly, this surprised me. 20% of the listeners were healthcare professionals, which I was very happy about. I was really, really
Yeah.
happy about that. Yeah. But a lot of people also requested to talk more about international problems. And I've only ever practiced in this country. I do have patients that have come to me from other countries, but I otherwise don't have a lot of exposure. When you travel, you obviously, if you happen to travel to a different country, you usually are not, hopefully, not exploring the healthcare system
Yeah.
when you're traveling. But do you have any particular tips, I guess, that would be different for people? And of course, we don't have the time to go into like a whole bunch of different countries, but for people that are living outside of the US, I actually had a patient, or actually, I guess technically she's a client because I do coaching also,
Mhm.
working with clients if they can't come to see me in person in one of the states that I'm licensed in, then I meet with them online. And she had moved from Canada to the US, and she was raving about the healthcare in the US. She was like, it is amazing. And she was going on and on about all these things that in Canada she doesn't have access to, and how if you have
Mm.
EDS in Canada, they basically tell you, at some point it's going to become a palliative situation. You go on like their version of hospice and then you die. And she's like, what? Yeah, I'm in my 30s, and she's a healthcare professional herself. So, do you have any um, thoughts for people that are listening that are in a different country?
Hmm. As healthcare professional or as
Oh, I'm sorry.
patients?
I should say as patients. I'm sorry.
As patients.
Yeah.
Huh. Well, I mean, you would if you listen to some sources, the people would tell you we have a healthcare system that spends too much money for the outcomes we have. But
Mhm.
I think what what you will get in the U.S. You definitely you have the more power as a consumer. There's a lot of, um, I guess in general in the world, money opens doors to places. But I think like I was saying in the U.S. the we have this. Hopefully, if you're seeing somebody, that if you're hopefully you're seeing someone who is gonna provide patient-centered care, there's a lot of easier access to specialists than in places with a nationalized health system. They control how many specialists they have, so there's less specialists, so there's longer waits. If you wanna get an elective surgery, there's much longer waits. In the US, it's less. I can't say I know that much more about, international, how we differ from other international places. I know our drug prices here are are way more expensive, which is a shame. Um, just the way that I guess, people are able to negotiate the big payers are able to negotiate drug prices is different. So you can expect to pay more for your medications in the US, but you'd have quicker access to specialists and surgeries. If you're waiting a couple years for a knee surgery, you could probably come here and get it done right away. Uh, so those are some of the things. Anything else you want me to comment on? This is not an area that would consider myself an expert on by any stretch.
Sure. Well, I'll ask you the next question because as we're wrapping up here, and you can incorporate that international perspective if any of it happens to strike you. So, what about how patients can help you help them? We've talked about the crunch for time and how complex things have gotten
Mm,
and regulations. And so, if it's you or another internist, what can patients do that can really help them get better care? I know we've touched on this a little bit
sure.
already, but yeah, anything else?
Yeah, I do think it helps when patients bring a list of questions because, sometimes patients will, for whatever reason, they will forget to ask something that was most important to them. Maybe because
Mhm.
the physician jumps into the visit and says, "Oh, let's talk about your blood pressure," when really you came in, you wanted to talk about your knee.
Mhm.
So I would bring a list and I would give your most important complaint up front, even if you're embarrassed to share that complaint, because you don't want to like bring that up when the physician has their hand on the door about to leave the room. That does happen a surprising amount. The other thing I would like to say is there's a great doctor, Dr. Saul Wiener, who he wrote a book called On Becoming a Healer. He's a physician. I believe he's in the Chicago area still. And his research focuses on like when physicians are ignoring patient complaints or things patients say. So a patient will say, so here's the one of his examples in his book is like a woman came in with back pain and she mentions when she's talking to the physician, she says, "Oh, I haven't been able to go get my imaging test because I was taking care of my son." And the physician says, "Okay, all right, well, please go get the imaging test." Well, if you had asked about, wait a minute, tell me about your son. Oh, my son, he's 27. He has cerebral palsy. I have to lift him out of bed 5 times a day. So, like, if your physician doesn't know that you have a 27-year-old son that you're lifting out of bed 5 times a day, they might not realize that that's why you have back pain. And, that's just one example of many about like your physician should be listening to you, but also sometimes you have to guide them a little bit because, people are in a rush. Not everyone's taught to be a great listener. Everyone's, and it actually, in the long run, it saves everybody time to just get those kind of things out there.
Yeah, I love that. That makes sense. And we will find that book and link that in the show notes because I think that sounds like a really great book for the listeners to
Yeah.
check out.
And your clinician listeners, it's a really good book.
Mhm.
Just kind of reminding you why we do what we do, and
Yeah.
it reminding you to listen to your patients because they are giving you a lot of the answers. And if you're not paying attention, you miss it.
Yes, that is so, so true. So true. I will definitely check out that. I will definitely buy that book myself. So it sounds like a great read.
Yeah.
I like to end every episode with what I call a hypermobility hack. Do you have a hypermobility hack that you can share with us?
I I would say that I don't have a hypermobility hack, but I would say, if you have hypermobility spectrum disorder, Ehlers-Danlos syndrome, and you're seeing your physician, I would maybe offer them a resource. Tell them to listen to Bendy Bodies. Ask them, to please work with you on the condition, because like we need to spread awareness about this. And if for in order for your physician to help you, some of us are hard headed. We need we need things to bang us over the head a couple times before it gets our attention and we start to change behavior. So that would be the closest I can. I don't have like a specific hack other than than that. How to get your physician's attention, maybe.
No, I think that's great. I love that. I love that hack, especially since you mentioned share the podcast with them. So yeah, and that's the whole idea. If you're busy, the Ehlers-Danlos Society has a fantastic program called the ECHO program, but most doctors can't take that much time to learn about a set of conditions, even if it affects realistically, it actually may affect a significant portion of their population,
Mhm.
but they have to learn about so many things. So that's where I try to make the podcast, accessible so you can listen to it when you're
Yep.
driving to work and, you can pick out episodes that seem most pertinent to you. So Dr. Watto, thank you so much. It was so great to chat with you. Before we go, would you be able to share with me where people can learn more about you and if you are doing anything research wise, if you have any projects on the horizon that you want us to know about?
I would just say, the curbsiders.com is where our podcast, like our podcast show notes are. We have a pediatric medicine podcast called The Cribsiders. We have
Mm,
an addiction medicine podcast. We have a
wow.
medical teaching podcast, and they're all on there. You can type Curbsiders into any podcasting app and you can find our show. So subscribe to the show. And we're just constantly our goal is to some patients listen, but largely we're just trying to make people better clinicians. If you're working in primary care, hospital medicine, just kind of make your day easier by giving you a lot of knowledge on a topic. So next time you see the condition, you know what to do, you feel confident. And ultimately down the line, patients are benefiting because everyone's taking the best care of their patients.
It's a great show, and I love how practical it is, and I every episode I've listened to, I've loved. If that was
Thank
really,
you.
really helpful. So,
Well, thanks so much for having me on. This was a lot of fun, and I really look forward to learning more on this topic. And I'm not just saying that. It's like this is something I've now identified a new area, so full speed ahead on this. So thank you.
I love it. That's awesome. That's fantastic. Well, thank you again. It was so great to chat with you, and I know that the listeners are really gonna love hearing from you, and they will have really learned a lot.
All right, my pleasure.
I absolutely loved that conversation with Dr. Watto. He is so well spoken and obviously a really caring and empathetic doctor. And I love the fact that he is training other doctors. I hope that you feel inspired by this conversation because I feel myself super inspired and more hopeful for the future. I think more internists being aware of these conditions will be so important, and hopefully you learned some tips for how to work with your internist to get better care. Thank you so much for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. Please tell your friends, family, and healthcare professionals to listen to the podcast. If you'd like to dig deeper, you can meet with me one-on-one. You can visit the services page of my website at hypermobilitymd.com to learn more. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at hypermobilitymd. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.